Can I introduce Dr. Radix? All right. So I am thrilled to have Dr. Radix with us today, and he flew in from New York last night, so you can imagine what an adventure that was. So Dr. Radix is Senior Director of Research and Education and the Clinical Director of Transgender Health at the Callan Lord Clinic in New York. He's a clinical associate professor of medicine at NYU, and his background is internal medicine, infectious diseases, as well as he has degrees in tropical medicine and public health from the United Kingdom. He has over 20 years of experience in caring for transgender individuals, and he's really a sought-after speaker and consultant as relates to pretty much all health issues around transgender care. So he's been involved in guidelines around the WHO has put together, the Pan American Health Organization, the Asia Pacific Islands Transgender Network, and then currently is co-chair for the World Professional Association for Transgender Care Health. They're redoing their guidelines now, and so he's co-chairing that process. So with that, and then he's just a great speaker, and a great friend. So with that, I would welcome him to the podium. And thanks again for making the trip, Dr. Radix.
Thank you. Pardon? I think I'm on. Right.
You're hooked up.
Can you hear me okay? Perfect. All right. Good morning. And it is so pretty to look outside and see the snow and be inside. Okay. So, we're going to cover many different topics in transgender health today. And it's wonderful that we have so many different disciplines here, but I think that everyone hopefully will take something away from this presentation. So mainly we're going to talk about the realities of life for transgender people, why it might be difficult for them to engage in care in healthcare systems, talk a little bit about the discrimination that people face, and probably the best ways that you can work with people to, get them to trust you and to come into care. So, and I'll be talking obviously a little bit about STIs along the way, but I wanted just to start with a short clinical case. And what you're going to do is think about how you would approach this with any person who comes into your clinical practice, right? And then think about how you think it might be a little bit different for someone of trans experience. So this is a 38-year-old white transgender man who comes in with 4 days of burning on urination and lower abdominal cramping and says, I was exposed to gonorrhea. He has condomless sex with a cis male partner, and we'll go through some of these definitions, 4 days prior. He had a surgery. It's a type of a lower genital reconstruction surgery called a metoidioplasty. He had that done in Serbia. He's had top surgery, which is another term for mastectomy or removal of the breast, when he was 24. He socially transitioned when he was 20, and he's been on hormones. So he's the hormone he uses is testosterone. So he's on transdermal testosterone. So the provider who sees him, does a urine and anal gonorrhea, chlamydia, and syphilis testing, does a rapid HIV test, which is negative, and then treats him presumptively for gonorrhea because we know there was an exposure. And in fact, he does test positive both on the urine test and anal swab. So, I think one of the things that we need to be thinking about when someone like this comes in is like, oh my goodness, I don't understand maybe some of these terms, what surgeries you've had, but think about what is the impact, for example, of the testosterone that he's taking on STIs, susceptibility to STIs, what is it doing for fertility? Because maybe, this young man comes in and you think you've done everything, but he's a man of trans experience, and maybe you didn't think about the possibility he could be pregnant. Does the fact that he had genital reconstruction surgery change the evaluation that you're going to do? And think about how being on testosterone impacts other things that you might want to tell him about his health. And he's had mastectomy. What are you going to tell him about breast cancer screening? going forward. So these are all things, hopefully by the end of today, you're going to be fully equipped to answer. Okay. So I wanted just to start with the reality, which is that, probably a decade ago, we didn't hear very much about transgender people at all, right? Many of us had never, who working in healthcare, had never had training. And now all of a sudden it's all over the news. So you can pick up a magazine, you can pick up a paper, and you can see all of these people who are Laverne Cox, um, Chris Mosier, I don't know if you know, was on the US Olympic team, the first transgender man to compete as a trans person in the Olympics, and even National Geographic. So we're seeing everyone thinking and talking about these issues, but really in healthcare, it's especially important. So just a couple terms, so we're all on the same page. When we talk about biological sex, we're talking about, child is born, everyone wants to know, is it a boy or a girl, right? So we're thinking about anatomy, we're thinking about chromosomes, we're thinking about, how society generally sees people, but really it's about the kind of physical anatomy that you have. Your gender identity is different. It's how you feel about yourself. And most people who um, most people who have a penis feel masculine. Most people who have a vagina feel that they're a woman, but not everyone does. So gender identity is something really important that we ask people when they come in to see us. How do you see yourself? How do you define yourself? Gender expression is how you portray that to the world. So people can, dress and portray themselves in different ways. And when we talk about trans people, we're talking about anyone whose sense of themselves, sense of their gender, differs from the way they were assigned at birth. So, their birth certificate said one thing, the chromosomes said one thing, but how they feel about themselves is very different. So this case talks about a transgender man. So just remembering that anyone who defines themselves as transmasculine or a transgender man was assigned female at birth. So they have a uterus, they have a cervix, they have, ovaries, they can get pregnant. So as long as those organs are there, you have to, keep that in your head no matter how they present in front of you. So they may have been on hormones and they may have a deep voice, they may have facial hair, and you have to remember like what their organs are. You might see terms like female to male or FTM. And you'll see that sometimes we tend not to use that when we talk to our patients, but you may see it written down. Transgender women are people who are assigned male at birth. So, XY chromosomes, born with a penis, they identify as women or somewhere on the feminine spectrum. And again, there are other terms you might see like MTF being used or male to female. We tend not to use that. And just thinking, because when someone walks into you, you don't know what's under their clothes, right? So keeping an open mind about that. You'll see other terms as well, because not all transgender people identify as male or female. There are many people who identify as someone on the, along the spectrum. Some days they may wake up and feel more feminine, and some days they may wake up and feel more masculine. Or they may say, I don't feel like either. I'm just me, and just use my name and don't use a gender. So you'll see many different terms. So genderqueer, gender fluid, gender expansive, gender diverse, gender nonconforming, and it's an identity, and it's important to be able to recognize that when people come in. So one of the other questions I'm often asked is, well, it seems like we're seeing so much of this in the news, but how many people are really identifying as transgender in the United States? There are about between 1 and 1.4 million people, right? So for clinicians who have a clinical practice of, say, 2,000 people, you're going to see around a dozen folks in your practice, right? So it's important to think about that. The other thing is that it's definitely something that is much more prevalent in younger age groups. I think people are more comfortable coming out. But I see, I've had people walk into my office in their 80s and say, I've always felt this way and I've wanted to do something about it, but I couldn't. because I was worried about what my family would say, but I'm ready now. So I have 80-year-olds, 70-year-olds. I think the oldest I've had is an 88-year-old who's come in. So, we talked about people who are non-binary or gender non-conforming. It's a lot. So about a third of transgender people identify in that gender non-conforming identity. So many of them are assigned female at birth, and they tend to be younger age groups. But again, just remembering that people can present in many different ways. The other takeaway point, because we're working in STDs, most of us, is to remember that people of trans experience can have any sexual orientation. So they can be attracted to men, they can be attracted to women, they can be attracted to both, they can be attracted to other trans people. So keeping that in mind, and again, like not making assumptions. And this was a study that was done a couple years ago where they interviewed about 28,000 people who were transgender and asked them, how do you identify yourself? Who do you have sex with? And you can see here, it is all, oops, what did I do? I was trying to get a pointer, but I don't know if it works. You can see that it's all over the place, right? So again, when someone comes in, you need to ask the same questions that you would ask anyone about their sexual partners. One of the reasons we're here today is because, it is different for trans people. And one of the biggest differences is really about stigma and discrimination, right? That's what keeps people out of care. So when we talk about stigma, we're talking about, the internalized stigma that people have, the shame that they feel about who they are. But we're also talking about the discrimination that folks face on the outside. I don't know of a single, I see a lot of trans patients. I can't think of anyone who's walked in and said, my life has been great. I mean, everyone has been traumatized in some way, either disowned by parents, disowned by friends, by, other family members. But the biggest issues are around, the violence that people face, especially transgender women. I'm sure you're aware of this, that people get murdered because they're transgender. So about up to 60%, maybe even more, of people have said that they faced public harassment, even violence. People have a lot of challenges. I mean, you can take hormones and change your appearance, but what if you can't change your legal documents, right? That can keep you out of care, because you don't want to have to explain yourself every time you go into a medical office that, well, I look like this, but my ID is a very feminine name or a very masculine name because I haven't been able to change it, or haven't been able to change my insurance. We see higher rates of unemployment, higher rates of people not having insurance, because people often don't finish school. We see, like in my clinic, about 50% of transgender women never finished high school. Many of them left at 14 or 15 because they couldn't take being bullied or harassed anymore. And there's even I don't know if you can see here, there's even a website that tells you how many people have been murdered. And it's updated like every month to tell you how many people have been murdered this year because they've been because they're transgender. So just a few of the medical barriers. Many people are worried that they're going to be discriminated against, so they might not want to come in to see you. They're worried that people are going to, they're going to be humiliated, that people are going to ask intrusive questions, that maybe providers, nurses, just aren't familiar with trans identities. And because of that, many people don't go into care. I mean, we have a program in my clinic where when we see, people come in with chest pains, like, why did you come into the clinic? You should have called 911. But they come into us because they feel safe and they don't want to go to the hospital. So we have a program where we actually escort them to the hospital, and we'll stay with them because we've heard so many stories from clients about being treated differently. So just a few of the negative experiences we've seen. This was from the study from that was done in 2015 and published in 2017, that a quarter of trans people had to teach their provider how to take care of them. Just a few others. Some were refused medical care, specifically hormone-related care. We've also had and about a third of people had had a negative experience, just one of these things. Even providers being physically rough or abusive, which is really a sad thing. Just a little bit about medical transition. You know, you've probably heard this term, and this is like the journey that people take or the processes that people go through to feel more comfortable in their bodies, right? And it can be, it's not only medical. There's certainly different things that can be done. So people can change their names and ask you to use a different name or use a different pronoun for them. They can change how they dress. They can change their hairstyles. They can do medical interventions, and there are quite a few, as you'll see. So the medical interventions, not everyone does, okay? But you can see there's a long list here. So generally we say feminizing. So people who want to change their appearance to be more feminine may decide to, in addition to changing how they dress, may decide to go on hormones. So estrogens usually. They may decide to take medications that block testosterone, and they may decide to have different surgeries. So, for example, breast augmentation or removal of the Adam's apple, and I'll show you a couple pictures, or genital surgery can be done, right? And for transgender men, taking hormones like testosterone can definitely change your appearance. But, you know, transgender men, they may decide that they want to have internal organs removed, like having a hysterectomy, or very specific surgeries, transgender surgeries, like creation of a penis. It's called a neophallus, and other procedures that you'll see. So I just put this up because people always say, oh, it's so new. We didn't learn about this in nursing school. We didn't learn about this when I was in pharmacy school. But you can see that we've been doing hormone care and transgender care actually since the 1930s when hormonal agents first became available. So we've been doing this a really long time, and it's quite a shame that we're not learning more about it in training. The most recent guideline is the Endocrine Society guideline. It was published in November. And I have some references you'll see. But you can see even in 1965, the first, they used to call it sexual reassignment surgery or SRS. We now call it gender affirming surgery, was performed in the United States. So that's before I was born, so quite some time ago. So there are many guidelines, as I said. A couple of things you might want to know when someone's in front of you. You know, you want to get a sense of their history, right? You know, you want to know if they're on hormones. You're definitely going to need to know if they've had any surgeries because it's going to help you decide what kind of screenings they're going to have. You want to take a full sexual health history. You want to know about other psychosocial issues, right? There are many transgender women who, because they can't get employed in the kind of regular employment kind of sector, often work in sex work, right? So you're going to need to know things like that. You want to know about if they've been able to change their names legally and have correct documentation, because you're going to be writing prescriptions for them, or you're going to be filling prescriptions if you're a pharmacist. So you know, it's important to know all of these things because it's definitely going to affect care. So I did say social transition, like whether or not people are binding or tucking, right? So I wanted to show you some pictures of this. So binders are what some transgender men wear to bind the breasts. You can actually get a binder. This is a picture of a binder. But some trans men will actually use even duct tape to tape the breasts down. For transgender women, they may tuck their genitals. This can also have an impact on healthcare, right? Because if you're tucking all the time, usually you can use something called a gaff. If you're taping your genitals with duct tape and putting many layers of tight underwear, you can get skin abrasions, you can get ulcers, you can get sores, and all of those things could increase your susceptibility to an STI. So these are all things to think about. So I didn't put a lot of detail here, but I just wanted to say, you know, for feminizing regimens, hormones, mainly we use estrogens, different types of estrogens. They can be pills, injections, patches. You can even do pellets or implants. So there are many different types of estrogens that people use. It's important to document that. And there are also, for transgender women, we block testosterone because it's a very strong hormone. So we use different types of testosterone blockers or androgen blockers for that. You don't need to know all the names, but just knowing that these are medications that people use. And they change your body, right? So if you're taking estrogens and you're blocking testosterone, you're going to develop breasts. You're going to go through puberty, right? You'll develop breasts. Your body fat will change, so you'll get more. You'll get hips, right? That'll be different. Changes that women also see, they'll notice they don't get erections anymore because testosterone is blocked, and they'll have lower sperm counts, but you can still get a partner pregnant, right? So even though you're on all of these, it's still important to discuss family planning with people. For transgender men, generally they're going to be on testosterone. Again, there are many different types. So there's gels you can use, injections, different long-acting injections, short-acting injections. And, just being on testosterone, it's going to change your appearance. So you're going to get facial hair. You can see this gentleman here has developed facial hair, a beard. You're going to get muscles, like more muscle mass. The periods will often go away. The periods will stop. The clitoris does get larger. And you can get atrophic vaginitis. So you get the same changes that, say, a postmenopausal woman will get. So you'll get vaginal dryness. And, one of the things we talk about with folks who are still having sex using their vaginas is you're going to need to use a lot of lubricant because otherwise you can get tears. And, again, that could be a risk for an STI. So, these are all changes that happen, and it's important to know about that. I'm not going to talk a lot about surgeries, only just to say that, many more people are having surgeries now because it's covered by so many more insurances, and we have more surgeons who are doing the surgery. So if Medicare has covered almost all transgender surgeries, actually since 2014. So, which is another reason why we're seeing a lot of older people coming in, because I've wanted to do this my whole life. I couldn't, but now I have Medicare. Medicaid is state by state, but even if you're in a state that doesn't have it under Medicaid, commercial insurances may still cover it, right? So you'll see more and more people coming in. I went through this before, but I just wanted to talk about just a couple surgeries that you might see that your clients have had. The first is that for many transgender men, removal of the breast is something that is really, really important to them, right? People have a lot of dysphoria, a lot of unhappiness around the fact that they have breasts. So removal of the breast is important. So just a couple pictures. This is one of my clients who's like right after surgery, and you can see a lot of the breast tissue is removed, not all of the breast tissue, but they remove most of it. You still have to talk to people about breast cancer screening, but for the most part, they'll have a very masculine appearing chest after that. For women who have an Adam's apple, it can be very obvious, right? So some women will have that removed. It's called a tracheal shave. Also, because many transgender women have already gone through puberty and already have reached their height and their kind of facial bone changes, people often still see them as looking typically masculine, right? So some women may decide to have surgery done on their faces. It's just kind of facial surgery that's done. And it's very small changes, but it can make a huge difference just to their life and being accepted in the world. For transgender men, it's just a small picture, but may decide that, I want to have a penis. And it is possible to do it. What they generally do is take some tissue, usually from the forearm, but they can also take it from the chest wall or from the thigh. Anywhere you can get tissue, and you basically make a tube, right? So this is just showing how it's done. The flap is taken from the forearm, its tube is created, and then often implants are placed. So there are all these like hydraulic pumps and things that happen. It's important to know what surgeries people have had, as I said, because it is going to make a difference for screening purposes. Some transgender men have a different type of surgery done. This is the first case I presented. This person had a metoidioplasty done. A metoidioplasty is a different type of surgery where they basically take the clitoris, which is now larger because you've been taking testosterone, and they do a clitoral release, so you gain some additional length, but it's your original tissue and really nothing else has changed, right? So you can do other things like create, put in testicular implants. You can do some scrotoplasty to create a scrotum. So there are other plastic surgery techniques that are done. I think the main takeaway message on these is that whatever lower surgery you've had done, you may still keep the internal organs, right? There are many people who have metoidioplasties who still have a vagina, who still have a cervix, who still have a uterus. So even though they've had lower surgery, they can still get pregnant, and they can still have, a cervical infection. So, I think what happens a lot of the time is people hear, oh, they've had genital surgery, so I don't need to worry about that anymore. But absolutely is something to be concerned about. So for transgender men, you can still have a cervix. So we often, you have to ask people what surgeries you've had done and what you still have left. Find out if they still have a cervix and a uterus, and then do appropriate screening. So, and if you have a cervix, you still have to do cervical cancer screening too. For transgender women who decide that they want to have a vagina, the one thing is that in order to have a vagina, they need to remove all the original tissues. So they will have the penises removed, the testes are removed, and they use the tissue usually from the penis to create the vagina. So they create a pocket. In a few cases, especially probably 20, 30 years ago, more often they used to actually take a loop of Babel and use that as to create the vagina. So you create a space after removing all the original tissue. You create a space, and you will have a vagina. And I do have a post-surgical picture, so I'm just going to give you a heads up on that. So this is just a picture of the pocket that's made using the original tissue, so penile and scrotal tissue. And then this is someone who's right after surgery. So they create labia, they have a vagina, everything is there. So you can do an exam and everything else afterwards. So this is a nice picture from a chapter that was written, just showing just some important landmarks that you can still, you can see here, if this will show up, but you can see the new vagina or the neovagina. The one thing to remember is that you never remove the prostate. That's the only tissue that they have to leave behind, because it's very hard to take the prostate away. But if you're doing an evaluation, you can use a speculum, small speculum, to do a check. You can have women do their own swabs. They can do a self-swab if you're worried about STIs. And and if you need to do a prostate check, you do that. I just put this slide down, not for you to memorize it, but just to see that, yes, you absolutely can get an infection, an STD, if you have a neovagina. The main things that we worry about are genital warts and gonorrhea. So those are the two things. There's really not anything else that's being reported. So HPV-related issues and gonorrhea. And you can see here, doing a speculum exam on someone who has a neovagina, you can actually see warts. I mean, it's not, it's tissue, right? So it's penile tissue, so it's just like skin. So anything you can see on skin, you can see. So it's just a little about HIV and STIs. We're not, talking about HIV particularly today, but just to remember that, HIV is a big issue globally. We know that, right? So where do trans people fit in here? So we know that there are about 37, 38 people living with HIV globally. In 2016, there were 1.8 newly diagnosed folks, and there were about 1 million age-related deaths. When we look at transgender people, the one thing is that transgender women actually have probably the highest rates of HIV of any group. We didn't look at it before because we always used to count transgender women under the MSM. I'm sure you remember the days when that happened, because they were like, well, they have a penis and they have sex with men, so we're just going to put them under MSM. But we now know that it's very, very different, right? That people have different risk factors. They're less likely to be engaged in care. It's harder to get people on medication because they're just so fearful of coming into care. So just you can see on this map, this was a study that was published by Steph Barral where they looked at all of the countries that actually had taken data and separated them out. So they had MSM data and then they had data for transgender women. And as you can see, many countries still haven't separated. But in the countries that had, you're seeing rates of, 1 in 3, 1 in 4 transgender women living with HIV. In the United States, we also have some data on transgender men, but very few studies. And some of the studies were so tiny that there were only 1 or 2 transgender men who were HIV positive. But, transgender men who have sex with men are going to be at risk, right? Because they're going to have many of them identify as gay and they're having partnerships with gay men. A little bit about STIs. We don't have a lot of data on trans people, but for transgender women, whenever they've looked, the rates of STIs are higher. So whether you're looking, you'll hear a lot today about gonorrhea, chlamydia, and syphilis. When they've looked at the rates in transgender women, they're actually higher than the rates of gonorrhea, chlamydia, and syphilis than in MSM or cisgender women. Cisgender women are, I should have said, I don't think that was one of the definitions. When I say cisgender, it means that anyone who was assigned female at birth who identifies as a woman, or who was assigned male at birth who identifies as a man. So most people in this room are cisgender. So we say cisgender and transgender, so you kind of can keep it separate. So we don't know a lot about neovaginal risks for HIV, but as I said, you can get warts and you can get gonorrhea if you have a neovagina. For transgender men, we don't know a lot, but for transgender men who have sex with men or cisgender men, definitely there's a risk. So, because many of the men that we see are having anal sex, they're having vaginal sex, they're often not using condoms, so they need to be screened after taking take a good sexual health history and make sure you're doing the right screening. Just a little bit about, when someone comes in to see you, because we already talked about the fact that people are often really afraid because they don't want to get abused or humiliated in a provider's office, right? I think that there's also the part that, when you walk in, you can imagine, you walk in as a transgender man, you have a beard, and people aren't expecting that you have a cervix and a vagina, right? So there's that bit where the provider might get, or the nurse might get a little bit, embarrassed because maybe they've not seen this before, and then the patient doesn't feel good, right? So just a few things that, to keep in mind. The first thing is that people don't want their business all over the place. So, confidentiality is really, really huge. And even if you maintain confidentiality, telling clients that you do is always super important. I had a patient who told me about going to a provider, and she was telling me the story and she started crying. She said, she went to this new doctor, it was a physician, and she disclosed to the provider that she was a transgender woman, and during the history taking, And the provider all of a sudden got up and left the room, and she didn't know what was going on. And then, she was sitting there for a long time, and then the door opened, and the nurse came in and looked, kind of stared at her, walked out. And then the front desk person walked in, stared at her, and walked out. So clearly the provider had walked out and told everyone, that woman who just walked in my office, but she's transgender, like a transgender woman. So, she knew that everyone knew. And then the provider came back in with gloves on and wore gloves for the rest of the visit. Like there was something wrong with her, and she felt so humiliated that she never went back. And it was quite disturbing. So a few other things, right? So, offer people a friend or a chaperone. It might be the first time that they've ever taken their clothes off in front of a provider, so that can help. Think about the terms that you're using, right? So using gender neutral terms, and I'll show you some examples, but that's pretty important. They're coming in for an STI check. At some point, you're probably going to have to do an exam, but sometimes, you're going to have to get people super comfortable and acknowledge that it's tough. Like, this is really tough for everyone, but I understand why it might be harder for you. Explain why you're doing the exam, because that, it's not just that you want to see what's there. You really need to do an exam to make sure that you're providing the right level of care. Some people use other terms to talk about their body parts, and sometimes I find that it helps to have that conversation up front, right? So what I usually say to people is, when I do the exam, some people like me to use medical terms when I do this. So other people just don't want me to say anything and just get the exam done with. Like, how do you want me to do this? Do you have any words that you use to describe your body parts? And sometimes people may just kind of volunteer that anyway. So asking people about relationships. We've always been taught that do you have sex with men, women, or both? But trying to use less gendered terms is also important. So tell me about your relationships, your current relationships. How many partners have you had in the last 3 months? What are the genders of your sexual partners, right? Because, we forget that, my partner might be a woman, but what if my partner's a transgender woman, right? Isn't it important that you know that, and that you know that maybe my partner has body parts that maybe you weren't expecting? What kind of sex are you having? How do you protect yourself? How often do you use barriers? What about when you don't use barriers? So inviting people to be open and honest is super important. We talked about language. So this is, I use a lot of internal organs, external organs, body parts. I'm going to examine the skin, around your body parts. So you can use terms that are less gendered. Transgender men who have vaginas often want you to use terms like front hole instead of vagina. Again, that's something that they might tell you. They might want you to use chest instead of breasts, even if they haven't had top surgery. So those are all things that you can do to make it a little more comfortable for folks. So just a few things. So take the anatomic inventory, right? So you're going to have to ask people what surgeries they've had, and you want to ask them what organs are still there. You're going to, if someone's had a vaginoplasty, explain that you're going to be doing a speculum exam. Might be the first time they've ever had it since they've had surgery. You're going to use a small speculum, remember, because it's not as stretchy. You're going to use swabs. It's very hard all the studies that have picked up gonorrhea in transgender women with who have vaginas, they're not picked up doing a urine specimen, they're picked up doing a swab. For transgender men who've had lower surgery, they might have had a metoidioplasty or phalloplasty. They can still have a vagina, so make sure you ask. So ask them if the vagina was removed. And there's a type of, if they've had a phalloplasty and the urethra was extended, or they had a metoidioplasty and the urethra was extended, so they stand up to urinate and they urinate through their neophallus, you can't do a urine test to check vaginal of any, cervicitis. You can't check gonorrhea and chlamydia that way. So just because, so it's important that you know. So explain the reason why you're asking. So I usually say, I'm going to ask you about the surgeries you've had, and I need to ask this because it's important for me to know what type of screening test to use, right? Whether I'm going to do a urine test or whether I'm going to have to do swabs. So we ask about that. I think I have just a couple slides on fertility. There may be a question on this. So for trans men who are on testosterone, right, their periods can stop, they can still get pregnant. So we always ask people about, ask questions like, are you planning on having biological children, genetic offspring? Because, we need to know this, first of all, before we start you on testosterone, because that's not very good to be on testosterone and pregnant. So if you don't want to get pregnant, we're going to talk about options, and the options are usually condoms, IUDs. You can also use Depo-Provera, right? So oral contraceptives usually aren't an option for people if they're also on testosterone. So those, we talk about that. We talk to them about the importance of having a pap smear if you still have a cervix. The one thing is, because the tissue gets very dry when you're on testosterone, sometimes when you get the pap, it comes back inadequate or insufficient cells. So I usually give people a heads up about that too. That it might be a little more difficult to do the pap, and it might come back insufficient cells. We might have to do it again, which no one wants to hear. You can get pregnant, as I said. So when people come in, like the first case, you probably thought, wow, the provider handled that really well. The provider never asked about pregnancy, never talked about fertility. So it's one thing you really want to know about. In one study where they looked at transgender men who were pregnant, a number of them had actually conceived while they were on testosterone, and they weren't having periods. So, it's important to think about that, whether you're doing STIs, whether you're putting someone on PrEP, anything. Just think about, maybe I should also do a pregnancy test. I just wanted to put in a couple slides about, and I do have time, about how you can make things a little better for your clients. And I put this is also based on a patient of mine. This is a 26-year-old woman who has a cis male partner, hypertension. She had a vaginoplasty. It was a penile inversion vaginoplasty. She's on estrogens, and her blood pressure is being treated. But this is what happened to her. She went into a new provider's office. She had to fill out a registration form, and it asked her, M or F, so she checked female. And then there were all these questions for women, like pap smears, last menstrual period. And the provider saw her, took care of the blood pressure, and then was like, oh, you need to see GYN, you need to have a pap smear. And she never went back, right? And I think, thinking about how people, when they come into your space, when they come into your clinics, if they don't feel included, they're not going to want to come back, right? That was, so this was, we asked people, what do you want? And most people said, I want respectful care. I don't want people to make assumptions about who I am and what my body parts are. I want providers who are open-minded and knowledgeable and who've been trained, right? So, people want to walk into your space, and again, they want to feel comfortable. So we use like a trauma-informed care environment. So is it comfortable? Is it calm? When you walk in, do you feel included? Are there pictures with people who kind of look like you, or are there brochures around? When you look for a restroom, do you feel like it's going to be okay for you to use the restroom, or are you going to have to hold it till you go home? Because you're kind of afraid that if someone doesn't call you out, then maybe another patient might call you out for going into a particular restroom if you're not comfortable with, how you blend in. Are there rainbow stickers? That could be a sign, right? When you sign in, is there a registration form? Do people, like, when you call, do people automatically say sir or ma'am? And that's not who you are, right? They hear a deep voice and it's automatically sir. Think about how you can change your language, right? Can I help you instead of can I help you, sir? That's something simple. When you have registration forms, the registration forms that we now use, we actually ask people what their gender identity is, and we ask them what sex they were assigned at birth, because I need to know that too, right? So we ask people both. We ask people about their pronouns. And I have like a 1 minute, hopefully this will play. Yeah.
He, her, she, them. My pronouns are she, her, and hers, and they, them, and theirs.
Using the correct pronoun has the power to change the game. And is a step towards creating a supportive and respectful atmosphere.
She, his,
Hers.
Pronouns matter because people matter.
Pronouns are as diverse as our community.
Pronouns are as fluid as gender and sexual orientation. Today my pronoun is they. Tomorrow it could be different. And it's who I am.
Using a person's correct pronoun is a sign of respect.
Everyone deserves to be respected.
Everyone deserves to matter.
Him. She.
Hers.
He. Let the world know that your pronouns matter.
and show people that they matter by using the correct pronouns, because
Pronouns matter.
pronouns matter.
Pronouns matter. And I matter.
Okay. That was something that we made up at my work because there were so many issues with people being mispronounced in the workplace with colleagues, but with patients, and it was keeping people out of care. So this is our registration form where we've put in the two questions: sex assigned at birth and gender identity. And I put this in, but we also have it on our electronic health record. It does help to have people feel welcomed when they see those choices, like, oh my goodness, like you're thinking about me, right? So just a couple summary, right? So using people's pronouns and the name they want you to use, even if it's not maybe what's on their insurance. And we don't have a problem doing it with most, like someone comes in and their name is William and they say like, call me Bill. Like that's never an issue. So why should it be an issue if someone comes in and they say, my name is Nancy, and maybe it's something else on their insurance. So, we talked about this, building rapport before doing gentle exams and thinking about when you're asking questions, do I really need to know this to provide the right level of care? Or am I just want to know because I want to know, right? So thinking about that, explaining to people why you're doing things. We talked about this, using gender neutral terms, and just thinking about how very, very hard it was for that person to walk through the door and come in to see you, right? I put this here because there are a lot of materials that are out there that if you don't have them already in your clinics and settings, you can actually download them, or YouTube. We make some from my health center, but CDC also has materials. But you can get all of these. So, sprinkle them around. I think people will be really very happy that they see images that look like them. And these are some that are specifically for sexual health, for trans women and for trans men. Again, these you can download them, and you'll have all of these. I put on the slides just some resources that I usually give out. So there are resources that are mainly about hormone care and around surgeries that people might have. And we also have open access journals that you can read about trans health. And then there are some webinars and some additional side sets at Fenway and Calnord, where I work, has them, and UCSF also has. So I think that is it. And we have a little time for questions, right? Okay. Do I start with the inside?
Yeah,
Yes. Okay. Go ahead.
For transgender women, prostate screening exams indicated, blood tests.
Yeah. So if someone has a prostate, you do the screen. Same. We tend not to do. We're doing lots of screenings on prostates, and then we were doing none, and now the pendulum is moving back again. I think the one takeaway is that remember they have a prostate, because you can get prostatitis, if you have you have to be thinking about that, right? And often patients, will forget, right? So when I say, like, remember you have a prostate, they're like, oh, I forgot, they didn't take that away. So, yeah, you can,
Prostate cancer, have you seen it?
yes, seen prostate cancer, there are case reports. It's less common. But, if you have someone who walks in, and they're 70 years old and they're like, maybe they had pre-existing prostate cancer, right? Risk is certainly less when you start off in your 20s doing all of this. There was another question in here. Yes. Right. Sorry, I didn't repeat the first question, but so what would you do if you had a 14-year-old who comes in? I mean, generally, a supportive environment. Obviously, you want to make sure that they're seeing providers who understand about trans health. Usually for young people, and I didn't really talk about the young people, but we have different phases. So you can have children like tots, like who are 6 years old and say, I'm trans, and, you're not going to do anything medical for them, right? But generally when young children are approaching puberty, there may be a decision made to halt puberty and give them a few years to figure out who they are. So we use puberty blockers in that circumstance. When young people have already gone through puberty, so a 14, 15-year-old who's already gone through puberty, generally it's about, getting them the appropriate, behavioral health support, counseling for the parents. There's not very much that's done medically, although some providers, it may decide to do hormone care, but that's very much has to be because they're under 18. It's a very specific field, right? Adolescent medicine. Yes. Is there another question in here, or shall I read some of these? Let's see. Would love a copy of slides. You will get the slides. Can we have a copy of slides? There are lots of slides, questions. Okay, after trans men have top surgery, do they still need mammograms? Yes. The issue, I usually advise yes, because they usually leave about 15% of breast tissue behind for contouring, and you can palpate it. I mean, when I have a client who has a very strong family history of breast cancer, I usually send them to a breast surgeon who has experience in that, and we get all the breast tissue removed. But in general, the plastic surgeons who do this work leave a lot of breast tissue behind. You can palpate, but you may still have to do a mammogram.
On that ground, with males using estrogen for transgender, are they getting regular screenings and regular breast exams? I had 2 transgender come in with breasts, and they had never even
Right.
been taught how to do a breast exam.
Well, I hope you taught them. Good. Yes, for transgender women who are on estrogen, if they've been on estrogen more than 10 years, really, they really should be doing having clinical breast exams. And the recommendation is that they get screened like any other woman. Okay, so that's a good question. What does they mean? So some people don't use pronouns that are especially if they identify as gender nonconforming, non-binary, or genderqueer, may decide to use a pronoun that's not he or she. So they use they as a pronoun. So like I have my pronouns there. I use he or they, so I'm comfortable with either. So that's some people have to wrap their heads around it because it's like that's not grammatically correct, but it's fine. You can use it. It's fine. It's a singular they. If someone's had a phalloplasty, would we use swabs to test for gonorrhea and chlamydia instead of urine testing? So it depends on what organs they have, right? So if someone has a neophallus, they've had a phalloplasty, if they still have a vagina, you're going to need to use swabs for that, right? So you'll end up doing a urine and like vaginal swab, and if they're having anal sex, an anal swab, and if they're having oral sex, oral swabs, right? So you swab anything that touches another genital body part, right? So you need to do that. Do many trans men get total or partial hysterectomies? Many do, but it's not necessary, right? In Europe, they used to mandate that everyone got a hysterectomy, oophorectomy, and vaginectomy, so removal of the vagina before they did these surgeries. And it was paid for by the state, right? But in the US, people were paying out of pocket, and they were, it's like, well, I only have this much money, so I'm just going to get the phalloplasty, or I'm just going to get the metoidoplasty, and I'm leaving everything else in. Because it was a cost issue, and there's not really reason to. There are so many questions. Explain cisgender again. Cisgender is like most people here. You identify the way you were assigned at birth. And the reason we do that is because when I say, if you say transgender woman, and then you say women, it's kind of like you're saying transgender women aren't women. So what we say is transgender women and cisgender women, or transgender men and cisgender men, so that we understand that when we're talking about women, we're talking about all women. When we're talking about men, we're talking about all men. Does that make sense? Okay. Let's see. How do you go about doing a cervical cancer screen for those who've had meta surgery and still have a uterus and cervix intact and a scrotoplasty? If you've had a scrotoplasty done, they usually do a vaginectomy first because it covers everything up. So what guys will do if they want testicular implants, this is a great question. If they want to keep their vagina, what they do is they take the labia majora, so the larger lips, and they put the testicular implants there, and they don't like sew them together, right? So what they do with the scrotoplasty is they make a union between the labia, and then they put the testicular implants in. But you only can do that if you have your vagina removed, right? So what a lot of guys do, I want to keep my vagina, so I'll just put testicular implants in on the side and keep everything open. Does that make sense? But still, when you have metoidoplasty, because of scarring, it sometimes makes the introitus, right, the opening to the vagina, a little bit smaller. So you just have to be super careful. Use a smaller speculum. Use a lot, if you're going to do an exam. That was a good question. During vaginectomy, is the cervix removed? Yes. During vaginectomy, you can only have a vaginectomy or removal of the vagina if you've had a hysterectomy, a total hysterectomy, right? They have to remove everything, and then they remove the vagina too. What is the youngest age that gender surgery can be done in a person? Well, there are many different types of surgeries, right? So for a young trans man, you can get your breast removed at 14, but most surgeons are not going to do a phalloplasty or remove your uterus until you're over 21. And there are too many questions. Okay, I'm just saying. So, and I don't want to, I think I have like 3 more minutes. So was there another question here? Okay.
For trans men
Yes.
who have retained uterus and ovaries,
Mm-hmm.
could you expand on the issues regarding contraception? It seems like adding hormonal contraception and the tension between masculizing hormones, hormonal contraception really is complex.
It is. So generally we have long discussions with people about what they want, right? So so the question was, what do you do for transgender men who have intact organs and contraception, right? What has been done is we offer people the full kind of plate of contraception. What most transgender men are most comfortable with is something like an IUD, which is very effective and can be done, and Depo-Provera is used because it's actually helpful for people who are on lower doses of testosterone who may have breakthrough bleeding. It actually helps with that. So it's actually recommended by the Endocrine Society as something you can do for people who are on a lower dose of testosterone. Not everyone wants to be on a high dose. There are people who are like, oh, I just want to see how I feel. Or they're using transdermal testosterone that is not as effective, especially in the first year, as suppressing menses. You can also do implants. In our clinic, that's what we do. But you're not going to be, what we don't recommend is, like oral combined contraception, like pills. We don't do that. And that would be a bit of a, like, too much of everything. And we don't even know how they would work together. So that was a great question. One more question. Yes.
The high doses of medicines that are necessary, does it increase the probability of cancer down the road or other health issues?
Yeah, I mean, definitely other health issues. For example, for transgender women who are on estrogens, there's a higher rate of blood clots, right? So deep vein thrombosis, pulmonary emboli, higher rates of cardiovascular disease. I mean, some of it's confounded by the fact that a lot of people are also smoking, or they're also living with HIV, or, there are other things that can increase risk, but there's definitely changes that happen when you're on estrogens. There increase in certain of the, inflammatory factors, and we know that they contribute. So there's that for transgender. Oh, and also, like, you have your bone mineral density decreases, so there are higher rates of osteoporosis. So you have to be thinking about all of that. For transgender men, we're not as sure, but definitely one thing that happens when you're on high doses of testosterone is that it converts to estrogen, right? So when you're young, it's not as big of an issue. But as you get older, when you're thinking of having all of that additional estrogen in your body, maybe when you're 50, 60, and you still have a uterus, that could be a problem. So, we generally just caution people, like, we're going to be doing screenings on you. We may be doing more than is necessary, but it's all because we're not 100% sure about the long-term risks. So, yeah.
We'll try that. We'll give you the rest of the questions. We can put in the emails when we call.
Okay, that's fine, because it is. Okay.
All right.
Oh, there was, yeah, okay. There was a question there.